This is Dr. Amigues, your friendly rheumatologist. Such a pleasure to be here with you. We do those lives so that I can teach you a topic in rheumatology so that you can have more education, so that knowledge is power, and that way you can make informed decision when it comes to your care. Maybe you figure out something when it comes to your diagnosis. Maybe you figure out something when it comes to your treatment. Those are not medical advice. However, I'm a physician, so of course, they correspond to my training, my double training, both in France and in the US in rheumatology. All right. So if you are just joining for the first time, know that we have previous Rheumatology 101 lives. You can actually look at them on YouTube. They are at Rheumatology 101 by Dr. Amigues, Amigues. If you do this, you will find in the live section all of them. And the last 2 episodes were about lupus. So we first did what is lupus. We then did how do we diagnose lupus. And today we're going to talk about how we treat lupus. And so without further ado, let me tell you a first story. Okay. So recently, actually not so recently, but maybe like about a year or 2 ago, I had a patient that came to me with very low platelet in the sense of basically she was bleeding, and there was some platelet issues when they had looked at the blood work. And, it took a little bit of time to make a diagnosis. She had seen a couple of other rheumatologists, but ultimately she had some joint pain with inflammation. It's pretty obvious. She also had a rash, and she had a positive ANA, a positive dsDNA, and a low complement level. In the setting of low platelet, then you have to say that the low platelet are probably related to the lupus diagnosis that we made. And in her case, basically, we started with Plaquenil, but we knew that that would not be enough. Our hematologist had started with treatment to help the platelet get, go up, because we knew that it was an autoimmune issue. And really, what really helped her was something called Benlysta, which is an injection. It's a biologic. And that has put her in remission. And for the past year, she has been in full remission. Her platelets are normal. She had no more joint pain. She has no more skin rash. That's such a cool story, right? Because technically she had severe lupus, but she's perfect now. And it's just a matter of finding the right treatment. I want to share another story, and then we'll put them all together, right? Young patient who had a minor rash. Remember, it's that rash that's like looking like as if you have a mask in front of you. And she had joint pain, and she had some hair loss with patches of hair loss. And well, this patient has a positive ANA, low complement, positive dsDNA, and we put her on Plaquenil, and she's in perfect remission, no problem. Okay, so that gives you a little bit more severe, a little bit less severe. And then I want to talk about patients with nephritis. Some of those patients come to the rheumatologist. Some of those patients go directly to a nephrologist. I have the utmost respect for nephrologists who take care of lupus patients. I work very close with one of the best nephrologists I've ever met at Anschutz. And so we talk a lot about our patients. And what you have to understand is that sometimes it just affects the kidneys. But that can cause a ton of inflammation of the kidneys. And that's really a problem, because if you don't see, you don't necessarily realize that you have a problem in your kidneys unless you're checking your blood pressure, unless you're looking and you're like, wow, I'm retaining a little bit more water. Like, why does my ankle have more, are bigger, or fatigue? And then when you do blood work, you're seeing that there's an issue with the kidneys. So if you have kidney involvement, depending on the stage that you have, there are different stages, and it's not really stage from less worse to more worse, to bad. It's more like different evidence of what you have. Is there more inflammation? Is there more scarring? What type of inflammatory process is there? That also is treated usually with a little bit more immunosuppression. Usually we do steroids, we do Celcept or Cytoxan, which is a chemotherapeutic agent. I prefer Celsep personally, but sometimes you have no choice. You do Cytoxan. And then sometimes we can add some other stuff as well. Okay. So the reason I talk about those cases is, number one, all of those cases doing well, right? They all did well. Number two is to realize that not all lupus are the same. And so you cannot just listen to anyone online telling you, oh, you should do this, or oh, you should do that, because depending on how you present as a lupus patient, you're going to have a different type of treatment. And so that, to me, is extremely important, that you get that notion of the most important thing at first is to know how severe your lupus is. Is your lupus only affecting your joint and your skin and your hair, maybe, your mucosa with oral ulcer? Then that most likely will be okay with just Plaquenil, right? So that's Plaquenil or hydroxychloroquine, standard of care. Everyone needs that. I'll go into why after. But then you look, is our patient having severe cases of lupus? Do they have, remember the case I was telling you like the first episode of lupus, when I was talking to you about this patient who had vasculitis due to lupus, when there was inflammation of his brain, and then he had hemiplegia. Well, this patient, you're going to give them a lot more immunosuppression. And so I think we had started with Cytoxan and then switched to Celsep afterward, in addition to the Plaquenil and steroids, a lot of steroid at first. The patient who has lupus nephritis and that has a ton of inflammation of lupus nephritis, same thing. You want to be pretty, not active, but you want to be pretty aggressive. So here is the thing, and I'm sure you've heard me say this if you've followed me for a little bit now. When I say aggressive, I'm not saying that I'm going to, we're going to be aggressive. I'm just saying that basically, if you have a fire, you do not come with a pipette of water to remove the fire. You come with a big bucket of water, and then you get rid of the fire, right? And you have different space of fire. You may have a fire outside and just a contained fire. You just need a hose and you take care of that. You may have a fire of the house. Then you need, the truck with the big hose to get rid of that. You may have a fire of a forest, and then in those cases, you need the Canadair, so the big plane with those products and water to get rid of this. And so you're not going to put a Canadair on just a fire that's in your yard. You're not going to put a Canadair of just one house. But if you have one house, if you have a fire of the whole forest, you need more than just a pipette. Okay, so that is really just so that you understand how we think as rheumatologists. And the reason that is so important is that there is a window of opportunity to get you to full remission as fast as possible so that you do not have any sort of issues. And so we make sure that you don't have long-term issues. Sorry, I was thinking, hi, Rock Dog, and I'm actually going to say hi to everyone. Hi, Dr. Amna Shabir. Hi, Diva. Hi, Lola. And hi, Roberts. I don't know. So it's such a pleasure to see everyone here. But yeah, so basically, depending on how you present with your lupus and how severe your lupus is, you're going to do different option of treatment. Now, because I really want you to understand the different type of treatment, if you have lupus, that will be helpful for you. So Plaquenil or hydroxychloroquine is an anti-malarial that doesn't actually work for malaria anymore, that used to work. And, as malaria, just it changes out of the time. And so basically they create resistance. So we don't actually use Plaquenil for malaria. But as always, there was a very smart rheumatologist probably out there that saw that one of his patients with lupus that was on Plaquenil did really well on Plaquenil. And that as they were taking them off, did not do so well. So that is how we started using Plaquenil as a treatment for lupus. And the really cool thing, and I was involved in some of those studies, the really cool thing about hydroxychloroquine is that it can treat moderate to minimal severe lupus, or not super severe, but moderate minimal. but most importantly, it prevents flare. And I was involved at HSS in Cornell in New York City in a study where we looked at that. And we would see that patients who had stopped their Plaquenil would have flare afterwards. And so it is standard of care. Everyone that has lupus should be on Plaquenil, not so much for treatment, but rather to prevent any flares. Because remember, if you're here and then you have inflammation, every time you have inflammation, there is a risk of scarring of the tissue. And scarring of tissue is just not great for us because it doesn't have the full function of your tissue. Okay. It's there, it just doesn't work as well. Okay. So your first line, Plaquenil. Everyone is on Plaquenil, unless you have complication, like you have contraindication for it. But everyone should be on Plaquenil. It's not even immunosuppressive, so no risk from that. Very well tolerated. It's even safe for pregnant women. Great. Okay. And then you go into, okay, well, if that is not working, or if you have, so we're going to take the first case that I was telling you, the second case, joint pain, skin disease, Plaquenil could be enough. You have joint pain, Plaquenil is not enough. You can add something like methotrexate that can help sometimes, or you can go to something called Benlysta or Safnelo. Those are two biologics. They made the news because they were the first FDA-approved treatment in lupus after many years. And so it was really an excitement for the community. I will tell you, I am blown away by how good they work. It is really, really cool to be a rheumatologist and see our patients get into remission thanks to this. Note, I said remission, I did not say cure. Remission means you have no sign of disease, but you may still have the disease, but we need medication. Cured would mean that I've stopped all treatment and you have no sign of disease. So it's much harder for me as a rheumatologist to say that someone is cured, because the vast majority of time we need something, to stay. And sometimes you just need Plaquenil, even if you have had at first some other medications. Okay, so Plaquenil, then we talked Benlysta as well as Safnelo. We even talked about a little bit of methotrexate. Now, if you have severe lupus nephritis, so inflammation of the kidney, heart disease, if you have like brain issues, if you have gut issues that are really severe, in those cases, or if you have low platelet, like I was telling you about, in those cases, we may actually do more. So we like Cellcept and Cytoxan for lupus nephritis. Why? Just because we have done studies on that. Okay, so there are a bunch of studies that are showing that Cellcept works really great. Sometimes we use Cytoxan, which is this strong chemotherapeutic agent. I don't like it that much, but there are some times where you want to hit and you don't want to wait. And so you're going to basically just like, imagine the Canadair, right? Like the plane with all of its product to put out the fire, then you back off, right? So you put out the fire and then you slowly come off of immunosuppression. Okay, so it sounds super easy. It's of course not as easy as it sounds. Hopefully it sounds easy. I hope it sounds easy. But yeah, really, like I think what's really, really important is to realize that not everyone is the same. Not all lupus are the same, and all lupus can be hopeful. All of them. And I really mean it. Even the worst lupus, the one that's being evaluated in the hospital all of the time, even that one can be hopeful because we have more and more new treatments. So now we have something called CAR T treatment, CAR T cell treatment. It's almost like sort of a bone marrow sort of transplant. Definitely not something that we offer to every single patient. I don't know how to do that because it's a hematologist that would do that specialize in CAR T cell. But what I can tell you is that there are some patients who are really, really severe and they do really well after that. And so I think that that's really an exciting moment in rheumatology for lupus patients. And so I want to just, share how hopeful the whole field is. And I just saw, oh, hi, Nancy. So good to see you here. Such a pleasure. You're coming just as I'm wrapping things up, basically. But yeah, so overall, lupus, autoimmune condition, like really, We know how to diagnose it. It's usually through criteria that are for classification, but we still use it for diagnosis. And depending on how severe your lupus is, you're going to get different type of immunosuppression. You may not need immunosuppression necessarily, but you will at least need Plaquenil, hydroxychloroquine, very well tolerated. And then depending on your presentation, you get different type of treatments. Overall, follow with your rheumatologist, because the goal is full remission, and we can get there. Okay. Next week, we'll have a new topic. I'm not completely sure of what I want to talk about, so we'll see, maybe rheumatoid arthritis and lung disease. If you guys have something that you want to let me know, if you want to put it in the comment either now or later, go ahead. If there's a topic that you would want to discuss, maybe I can talk about vasculitis. I don't know. There's so many interesting topics in rheumatology. And as always, if you are looking for a rheumatologist in the Colorado area, I'm still taking new patients. We're actually increasing our price because our team is growing. We're increasing our price mid-April. So if you want to come in before, we'll keep the price that we have, and then we always grandfather our patients. So whatever you come in at this price is what you will be on every year. But until then, such a pleasure to see everyone, and I'll see you next week. Bye.